This talk is titled Operationalizing Health and Racial Equity Concepts in Health System Performance. So, I always talk in my work about, we say healthcare, we have to put the health in healthcare and focus on health. And as we think about disparities, particularly racial disparities, it's important for us to lift up and address racial injustice and how that shows up, and not only within our institutions, but within the ecosystem in which we operate. And so we're going to, deconstruct that for the next 45 minutes, and hopefully I will leave you with some new ways of thinking and tools and resources that can help us all as we grow and evolve in this important work that we're doing. You will receive the slides, but what I have here are just hyperlinks. Miriam had mentioned some of the publications. This is just a few of the work that I've been able to do with my colleagues around this topic. And so when you receive the slides, if you're interested in any of these, you just click on them and it'll take you to the source, and you can you'll have full access to the publications. So we're going to take some time just to reflect on the evolution of medicine, medical care, and historical injustices. We'll contextualize the institution of healthcare as a microcosm of a broader ecosystem that is rooted in racial injustice. And, we can't talk about quality without talking about racial equity and the importance of achieving racial equity, again, not only within the walls of our institutions, but in the society in which we live. And then I'll share some examples of some norms, institutional norms, things that we're doing that we're not aware of that perpetuate racial differences in patients' experiences, as well as their clinical outcomes. And then I always, want to be sure that I leave you with tools, resources, and just things that you can do immediately to improve your work, our work, and the work of the organizations and the missions of the organization that we're serving. Some of you've seen these. I always like to start out with these. I've been blessed to interview thousands and thousands of people about their healthcare experiences, particularly people who live in communities that have been historically marginalized and people of color. Just to learn more about those dynamics and their experiences, I think it's really important for us to be aware of these themes. And so what we've done, me and my colleagues, we've been able to capture themes and create these fictitious profiles that resonate with many people of color or people who have a different lived experience, right? People who have been historically disenfranchised and marginalized. And some of you have seen these before, but I want to start just by reminding us of, these narratives. Otis, they asked me a lot of questions about my pain. I think they assumed I was seeking drugs. Rashida, obesity and diabetes. It runs in my family. In the beginning, I felt like my providers thought I was lazy and didn't care about my health. Maria, my doctor tells me to eat healthy, but it's difficult. The grocery store is far away. The foods I can obtain, they're not very healthy, but they're affordable. This is my local grocery store. Anam, English is her second language. She feels like,
Wait, what was the topic you said?
Somebody's not mute. It happens all the time. So she says that I feel like they think I'm not very smart, again, just because English is her second language. Solomon, I don't connect with anything in my doctor's office, from the pamphlets to the magazines to the team that cares for me. No one looks like me. David is gay. My doctor knows, but we never discuss health risks that are specific to me. So I want you to just think about how these narratives impact patients' experiences and how they may engage with a provider or an institution. And we know that it's important for patients to be partners in the care that they are receiving, right? It's our responsibility to get to know them and understand the barriers and work with them so that goals can be met. But I would argue, and patients have told us very clearly, if they are seeing providers, and when I say providers, I'm talking about the institution, not necessarily the individual. If they're seeing providers or entering spaces where they just feel like they are not represented, we lose them, right? They are not going to be as engaged in their healthcare, medical care experiences. And that's not what we want, right? We want that engagement because that is key to achieving optimal outcomes. And so it's incumbent upon us to look at our environment and how we're operating and always critically audit the work that we're doing so that we can achieve that goal. Again, to make sure each person feels and knows that they're respected for their differences and their identity, and that we have a curiosity to know who they are so that we can better render care. So the paradigm shift, the old versus the new, right? We're going from a medical biomedical model of care. That's how this system has been designed, right? Very biomedically focused. Well, I would argue that we need to push forward, and many are arguing and pushing for healthcare, right? And to me, that means a biopsychosocial approach to how we render care. Race has been perceived and operationalized, I should say, as a biological risk factor. Well, we learned a lot from the Human Genome Project, right? Racism is a risk factor. So, we continue to, and again, we're operating in systems that take that race indicator and come up with all kinds of conclusions and decisions, and it's not always best for the patient. In many cases, it's harmful to the patient. And so we have to undo that. And it's going to take time and intentionality to do that. But I think we're on the pathway. Cultural humility or cultural competency, versus cultural humility, and I'll talk about that in just a few as well. So again, we're spending so much money on medical care in this country. I would argue we have not cracked the code on healthcare and what that really means. And that means that we recognize that health is mostly shaped by what's happening outside of the walls of our medical institutions. And that's why I'm really, really excited about the School of Health, because that is the space that we will be in, recognizing that medical care is important. Don't get us wrong. It's critical that we have access to high quality clinical care. But when patients go back into their communities, what does that look like, right? What does the home environment look like? And what can we do to bridge the gap between medical care and public health? And how do we use our voices, our resources, our agency to create communities where it's easy for people to make healthy choices? And so that's the space that we'll be in at the School of Health. Really, really exciting, necessary work. And we will use that work to inform clinical care delivery, right? Because when we're delivering care, it's important that we think beyond, again, the biology, but what's happening in that patient's environment. So how do we set up systems and processes, and how do we normalize that, and how we're interacting and engaging with patients in medical settings? So health is mostly shaped by social and economic factors, the physical environment. A lot of times health behaviors are correlated with social and economic factors. For example, the more educated you are, the less likely you are to smoke, right? So we see these trends, but it's important for us to have this very comprehensive perspective as we think about health, well-being. How do we improve systems of care to address, let's say, cure personalis, right? We want to care for the whole patient or person. So this is all just so important because, stepping back here, taking a bird's eye view of where we are in this country. I mean, the vertical axis represents life expectancy. The horizontal axis represents spending per capita. And you'll see here what we see are peer countries, and here we are, lovely United States, all the way over here, almost literally off the charts, right? So we are spending more when compared to other countries, and our life expectancy is among the lowest. And so clearly something is wrong. We're just not getting it right. And you can ask 100 people why are we in this zone, and you'll probably get 100 different responses that are all valid. But I'm here to talk about disparities and inequities, because we know that that is a significant contributor to spending in this country. And on the right, you can see disparities. We all know this, they're measurable, right? That's what a disparity is. It's a measurable difference when we're comparing populations. So it's a measurable difference in incidence, prevalence, mortality, or burden of disease when you're comparing comparable populations. And the estimated cost per year is like 93 billion. That's medical. And the 42 billion represents lost productivity, right? So 42 billion in lost productivity. I would argue we can't continue with this trend. We can't continue to be a robust economy. We can't maintain our position in the global market if we are a sick population. And so it's important for us to address this issue. And why do these disparities exist? They exist because of inequitable conditions. You know, it's very simple, but it's very complicated to fix. Inequitable conditions simply mean that you have these populations, you know, the people north of Main Street and the people south of Main Street. When one group has more opportunity than another, you will see measurable differences in health outcomes. All right, you're going to see these measurable differences, and that's what inequities are, when you don't have equal access to opportunity. So let's look at the District of Columbia. That's where we are. You know, we are a very segregated city, and you see east of the river is predominantly, or the further east you go in the city is predominantly Black, and then as you travel west to the western portions of the city, it's predominantly white. And so just looking at this map, this image here, me and my colleagues who do this work, we can already tell you, housing, the property of homes is going to be lower east of the city. Education, levels of educational attainment will be higher west of the city. You can just make these conclusions just by looking at how segregated a community is. And that's why we look at the residential segregation index. That's what it is. Residential segregation index is on a value of 0 to 100. And a value of 100 is a community that is completely segregated. A value of 0 is a community that's completely integrated. Residential segregation, that index, also known as the dissimilarity index, helps us, you can make a lot of inferences based on how segregated a community is. And so I think for DC, we're around 68 out of 100. And then here is some work that we have published just not too long ago. I know there's a lot here, but basically we looked at the two indicators that help us understand quality of life in a community, life expectancy and infant mortality, right? And you can see that infant mortality rates are higher east of the city, and life expectancy is higher west of the city, right? And so, you know, folks wonder what are the characteristics of these communities that help us understand. And I'm just choosing one indicator here for you today, and that's FS, that stands for full service grocery stores. I want you to think about this. Ward 7 and Ward 8 are comprised of about 160,000 people. Ward 7 and Ward 8. 3 full service grocery stores in those 2 wards. 3. So you need context, right? We all want context. What does another community look like? Is that normal? Is that okay? Is 3 full service grocery stores adequate for 160,000 people? I wouldn't know unless I looked at some comps, right? And so if you look at Ward 3, which is up here, 80,000, approximately 80,000 residents, predominantly white, 81% white, Ward 3. These 2 wards down here, 7 and 8, 92% Black. 16 full service grocery stores. 16 to accommodate 80,000 people. Again, 3 to accommodate 160,000 people. So we're interacting with patients who live in a community that has this type of structural makeup, our conversation may need to be just a little bit different, right? But our patients need to be comfortable expressing themselves and sharing and you know, disclosing some of these barriers. And we have to get better at how to ask these questions in ways are um, that are okay for people and our patients and ask these questions in ways that will help bridge the gap that we historically have had between patients and providers. So again, just context, I mean, it's just the District of Columbia. You can go to just about any city, community, and you'll see similar trends. But these structural conditions impact health in a negative way if people don't have access to opportunity. And so what does that mean for us, right, in the work that we do? So just sharing a couple of examples of some really cool models. ProMedica. I don't know if anyone is from Ohio, but ProMedica Health System, they have a food clinic or a food pantry on the premises of their hospital grounds. And so if a patient has been identified as being food insecure, and that patient, for example, needs medication and needs to be taken on a full stomach, that patient will get a prescription, not just for the medication, but for food. And they can go to the food clinic on the premises of the hospital grounds and get the food that they need. To me, that's healthcare, right? That's healthcare. That's thinking broad, thinking about the whole patient and not just prescribing that medication, because that's what we've been doing. We've just been prescribing the medication, not asking patients questions about food insecurity, right? And the two questions that they ask, the validated questions are, you know, it's a prospective and a retrospective question. It's like retrospective question is, have you missed a meal because of the inability to pay within the past 30 days, right? And the prospective question is, do you think you'll miss a meal within the next 30 days because of the inability to pay? And anytime anyone answers affirmative to either of those questions, they will be eligible for a prescription for the food. Health Leads down here, they do great work around just, you know, making sure that patients have access to their social needs are being met in primary care settings. And they've created this really amazing, it's proprietary, but it's an amazing platform that they use in their clinics to address social needs. And then this is a story, this woman, her name was Shanika James out of New Jersey. And this was a pretty big story because look, this is her apartment. And we see this a lot. We see particularly people who don't speak English as a primary language or immigrants who are paying their rent and their landlords are not providing, they're not investing or reinvesting in these dwellings and people are living in deplorable conditions. It's exploitation, right? That's what it is, it's exploitation. And so that's why we're seeing more medical legal partnerships. And we have a wonderful medical legal partnership here at Georgetown. And this is the work that needs to be done, right? And so think about how we've been operating for so long. We would treat Shanika and not ask questions about what her home environment looks like and not have the resources to do anything if we do learn that she's living in such deplorable conditions, right? And so, you know, if we are truly into health care, we're thinking about Shanika's holistic well-being, and we are partnering with community-based organizations to achieve wellness and health. And then let's see, I'm going to skip that. I'll come back to that. Let's go to the race piece. So earlier I was mentioning how, race has been perceived and operationalized as a biological risk factor. But it's really racism, right? And it truly is a risk factor, and it happens within the walls of our institutions, and it happens outside of the walls of our institutions. And when I engage in racial healing conversations, I always start off with this point. And I think it helps neutralize the environment because this is such a difficult topic for people, and it's hard for folks to have discussions around race. It's not easy, but I always say that if you have a pulse right now, right, we all are breathing and we're all present, cognitively aware of our surroundings. It's important for us to know that we have inherited this mess. We have inherited this. And while we are here, it's our responsibility to fix it so that we're leaving a future that's better for our children, our grandchildren. For me, it's my nieces and my nephews, right? And so how do we undo this? What does it take? Because, I'm Hazel King's son, and my mother is a true optimist. If anyone is interested in doing interviewing anybody about optimism, or you're looking for someone who can reflect that, it's my mother. I mean, she is the most optimistic person I've ever met. And I do get that from her. But I think that most people truly come to work each and every day with this intent to treat everybody the same, equally, equitably, right? I truly do believe that. But what I also know is that we are operating in a system that has not been designed for us to do that. We're operating in a system that has not been designed for us to do that. And it's important for us to each and every day look at how we do our work, how we're structured, how we're organized, how we make decisions, how we communicate to patients, how we communicate to each other, and critically audit how we're doing our work. And slowly we will chip away at bias, we'll chip away at racism and injustice that we're seeing in this country. But it takes intentionality, patience, and courage, because it's not easy work. I share this slide just for context. If we start with 1619, 246 years, slavery was the norm in this country, and segregation, 89 years, and that's a long time. And if you look from that whole 1865 to 1954, that's when we saw the more formal organization of healthcare, of medicine. And there was a lot that was being done during that time period. And just think about how Black and brown bodies were perceived at that time. And so, it's going to take time to undo the damage. And again, I share this with you just to remind us all that we are operating in a system that does not allow all people to achieve optimal health and well-being. And I would also argue that we're not even in the green zone. We're not in the green zone because of the persistence of voter suppression. We're not in the green zone because of George Floyd and Breonna Taylor. We're not in the green zone because of mass incarceration and all the other injustices we continue to see. So it's going to take time to undo this damage. And I'm just hoping that everyone who hears me will think about the influence that they can have, that you can have in your communities, in your own households, to undo the damage. So we're going through it, right? We're experiencing all kinds of change in the country. We're seeing statues and icons come down that symbolize hurt and pain for so many. This is part of what needs to be done for this country to heal. It's just what needs to be done. And I'm going to go quickly through how this applies to us in our work. This is, many of you know, are familiar with James Merriam Sims and father of gynecology, you know, celebrated in the textbooks as a hero. Obviously has a statue. Statue's removed now, by the way. But that's the history, and that's how he um, would show up in the medical literature. But you know, Betsy Anarcha and Lucy's stories weren't told. These were enslaved women that that he used to perfect the treatment of vaginal fistulas, right? And so Anarcha, Betsy, and Lucy, there's no statue of Anarcha, Betsy, and Lucy, right? And I know there's work that's being done in different spaces now to address that, but just think historically that's been the narrative, right? You have this father of gynecology celebrated as a hero, and Anarcha, Betsy, and Lucy, who were exposed to all kinds of painful surgical experimental procedures. So yes, this came down. I think it was in, oh goodness, it was a few years ago, and you know, we maternal mortality rates are high in this country, and the reasons for that are complex. But you know, I would argue that what women have said, they don't feel like they're heard or listened to, and I just wonder where's that coming from? And I would argue that it still comes from the teachings of Miriam Sims and how embedded that has been in the teaching and the practice of gynecology. 1932, Tuskegee Study. You know, it's prominently recognized because it was a federally endorsed study. But the Tuskegee Study just skims the surface of all of the injustices and all of the uncivil activities that were occurring in medicine that just harm Black and Brown people. Henrietta Lacks. And what about the contemporary manifestations, right? So I shared earlier with you that, you know, DC is a residentially segregated city, and you know, cities across the country are continue to be segregated. But you can see here, these are some recent publications. Excess 30-day heart failure readmissions and mortality in Black patients increase with neighborhood deprivation. The publication at the bottom is one of mine with one of my colleagues, Relationship of Hospital Star Ratings to Race, Education, and Community Income. So, you know, you're familiar with the 5-star ratings, CMS 5-star ratings. We wanted to know, we had our hypothesis, right? But you need to go through the discipline and the rigor and have a peer-reviewed study to demonstrate what many of us already knew, right? So we wanted to know, where were the 4- and 5-star hospitals located, right? And we found that 4- and 5-star hospitals were more likely to be located in communities that are affluent and white. And you had the reverse effect when you look at the 1- and 2-star hospitals. So what does that mean? You know, one thing that we do know is to exercise caution when you're looking at these hospital star ratings, because just because it's a 1- or 2-star hospital doesn't mean that the quality of the care is substandard, right? It may be in some cases, but mortality rates are factored into these ratings. And so if you have a hospital that has a high mortality rate and it's in a community where people are sicker, that's not the hospital's fault. You know, you can't blame the hospital, penalize the hospital. And that's why stratification and risk stratification is so important. It's a whole nother topic. But we just want to be sure that we just wanted to tell the story, you know, that the 4- and 5-star hospitals are more likely to be in communities that are affluent and white. And then redlining was banned 50 years ago. It's still hurting minorities today. And because we're becoming more digital, we're seeing how it's showing up in algorithms. Um, and algorithms are, they're smart, but they're created by humans. And again, this goes back to the bias that we have because of this world that has put all these messages and images and perceptions in our brains. And sometimes we can't smart our ways out of that, smart our way out of it. It happens so quickly. And that's what implicit bias is. So going back to our history, Blacks were perceived as inferior, genetically different, unintelligent, having thicker skin, possessing higher pain tolerance, being predisposed to violence. And these were beliefs that were institutionalized in the evolution of our healthcare system. This study was done in 2016. They looked at med students and found that these perceptions persist. Black, and I put an arrow by the ones that were highly recognized. One is Black people's blood coagulates more quickly than whites. Black skin is thicker than whites, right? And look at all of these different examples. I mean, all of these different biological fallacies. So the question is, where does it come from, right? It's like, were people explicitly told this? And again, I would argue that no, it's not that people are explicitly told this. It's just the messaging and case studies and the literature and what lead people to make these types of associations. And again, just the injustices that exist in our society. So that's when I say we've inherited a system that is rooted in injustice. This is a perfect example of what I mean. And it's like, what can we do to chip away at this type of thinking and these types of perceptions? So for us, we write about it, and we tell stories, and we do grand rounds. And for others, it's other things, right? And so what we did, one of my colleagues, just a couple of years, right at the beginning of COVID, because we were seeing, these racial disparities. We wrote a piece around reconceptualizing race in healthcare in the wake of COVID-19. And again, you can click on that and you can read that. And if you're interested in like who's who and this whole race piece and how do we rethink race, Jennifer Sy is amazing. And this is a piece that she wrote with a few colleagues. I think she's at Brown, if I'm not mistaken. And then this speaks to how race and public health are overlooked in medical research, or how public health is overlooked in medical research, I should say. So this study was released in 2020. And the authors, the publication, the journal got a lot of pushback because of the association between COVID and race, right? It's like, what they were pretty much suggesting was that there's a biological explanation for why Black people or people of color were dying or sicker, and they're just not doing as well as their white counterparts. And I'll read this little piece to you. It says, Black people were more likely to become infected with COVID. This is what the paper suggests. Black people were more likely to become infected with COVID because of a difference in gene expression in their nasal epithelia, omitting the fact that the gene in question is upregulated by poor air quality, which has been linked to residential segregation and environmental racism. So this is what I mean by think bigger. And we have a tendency to, I'm not going to say that. The industry has a tendency to simplify and just have this reductionist approach and just say, oh, it's because of race, or there's some type of biological difference. Well, it's the environment, right, that really does impact us. And that's what, work that we're doing over here in the School of Health. We have a human science department that's looking at, DNA expression and how and epigenetics, and how, conditions that we're exposed to chronically impact DNA expression. So how do we correct this 18th century classification system? I'm going to very quickly I'm not going to show you the clip here, but Dorothy Roberts is, I call her a national treasure, because she um, uh, has a great TED Talk, and you can click on this when you get the slides, and it'll take you right to it, around the problem with race-based medicine. And so if you're interested in learning more, she is one of the nation's leading authorities on this topic. Just very quickly, I just want to ask you, and we can talk about this when we go into discussion, how many of you have seen mannequins that are of color? And so I've been following this gentleman on Instagram. He has been creating these mannequins of color. And it's just little things like this that really do make a difference, right? This is going to help bridge that gap, with COVID, it really amplified that people of color have distrust of the healthcare delivery system. And I'll never forget speaking to a community of folks. And one gentleman said, well, I trust my doctor. I don't trust the system. And people, like, there was a round of applause. And for me, that was a major, major aha moment, right? So it's the system of care. What are you doing with my data? Now that we're becoming really, really digital, and we're looking at big data, and folks are just wondering what's happening with that, and how can that be used, or might that be used to inflict harm? Again, the Band-Aid, something I celebrated, my family, and it was such a big deal for people of color, right? To have Band-Aids that reflect various skin tones. And this just happened just a few years ago. So again, it's little things that we need to do. And when I say critically audit, this is a perfect example of what I'm talking about. We critically audit the world in which we live to be sure that all people are represented. My niece uh, does ballet, right? And she, for so long, she didn't have tights that reflected her skin tone. And so she had to use the tights that were the color of the Band-Aid on the far left on the screen. And her skin tone is the tone of the far right. And so for so long, she had to move about the world, and the ballerina world, with two different skin tones. And that's been changed now. So again, slowly progress is being made, but critically auditing our environment and making changes is key. This is Brigham and Women's Hospital. They went through a process a few years ago. They looked at all of the portraits of their department chairs and saw very little diversity, and decided they were going to change that. So how will we know that we have achieved racial justice in healthcare? I would say that we will know we have achieved racial justice in healthcare, or we're just racial justice in general, when we no longer have to ask the question, what is your race? Again, I'd love to have some discussion about this. Let me say that again. So we will know that we have achieved racial justice in healthcare when we no longer have to ask for a person's race. We no longer have to check the box. Why do I say that? Because race is a social construct. It is a social construct rooted in a racist 18th century classification system. And so if we no longer have to, and we still have to ask questions about race, why? Because of racism. So we still need to know people's race, because that helps us identify problems and where we need more targeted interventions. But I just pray for a day, and I know it will not be in my lifetime, but I pray for a day where we no longer will have to ask, what is your race? It will be a very, very archaic question, and no one will even understand what we're talking about. But we do need to know about, like, ancestry, right? That's important. Family history, that's important. But race is a social construct. And again, I would love to hear your thoughts on that. And I'm going to wrap up here with the difference between cultural competency and cultural humility. I think that, and I remember in the 90s when I was going to these mandatories, you got to go to your cultural competency training, you got to get trained on cultural competency. And I remember being told, if it's this particular group of people, then you do this. If it's this particular group of people, then you communicate like and we thought we were doing the right thing, but we were causing even more damage because we were putting people in buckets. We were putting people in these classifications. And we do that because it's very natural for us as humans. That's the way that it's comfortable for our brains to put things and organize things in buckets and make these types of associations. But that's, again, that can do more, that can cause problems, right? And do even more harm. So how do we achieve cultural humility, right? And that's when we're sitting down with each individual that we meet in our lives, patients, friends, someone at a conference, and we have a curiosity about who they are. And we humble ourselves, recognizing we don't have all the answers. And we listen to them and give them space. And they know that the space that they're in is a safe space because you've created an environment that is safe for them. So that's humility. And I have my own experience with my doctor. I got a new doctor a few years ago, primary care. And it was my first visit. So I go into the exam room. I'm sitting on the table, and she comes in and she's just talking to me, right? She didn't ask me to say or she didn't look at my ear. She didn't touch me. She sat down and asked me questions just about my work, family, what keeps me up at night, which I thought was a really, really interesting question, an important question. And I started to question, what's going on here? Is this a primary care visit, or is this a therapy visit, a psych visit, or what's going on here? And I asked her when she finished her questions, and we established, a really cool, way of interacting with each other. She said, Christopher, the relationship between the doctor and the patient is a very intimate one. And I don't touch any of my patients until we've had a conversation and I know a little bit about who they are. And to me, that's cultural humility, approaching each person that way and not making these assumptions about people just by, first impressions. And I share this story because to me, it was a very, very powerful experience. And I just really, really appreciate her. And she has got this cultural humility thing down. So this work is so important. I'm going to wrap up, but it's so important because it is a quality issue. It is a safety issue. We're seeing more accreditation bodies and folks who are providing certifications, ask questions around what are you doing in this space as an institution? Our students have an appetite for it. After George Floyd was murdered, students came back to campus ready to go. Like they really wanted to do some heavy lifting. And so our students are really, 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 they want to see that we are responding to this. It promotes trust and atonement. And it's just the right thing to do. But how do we operationalize change? Well, first, it's important for us to recognize equity as a quality and a safety issue, right? And so, every board has probably every healthcare board, a hospital board has a committee on quality, right? Or safety, or quality and safety. Is equity built into that? That's the question that I would ask. And that's the question that I do ask these hospital administrators as they share their quality initiatives. We have to embed these competencies in how we teach and how we train. Rethink implicit bias. So for so long I was doing implicit bias training focused on individual and not on the system. And so that's the space that I'm in now personally, is looking at systemic bias, right? How does bias show up in the systems in which we're operating in that go over our heads? We don't realize it. We have blind spots. And then fostering humility and training, listening to each other, learning from students, for me, and patients in the communities that we serve, because we do not have all of the answers. So